Hi, Dr. Adamson.
Hello, can you hear me?
Oh, yes, I can hear you now.
Great.
I'm Sarah. I'm the Harbor View Inpatient Chief.
Hi, Sarah. How are you doing?
I'm good. How are you?
I am all right.
Hold on. You should have the ability to share your
Looks like I do.
slides. Yep.
Out. Share screen. One sec, let me close a few things. Close that. What is that? That should be okay. Let's see now. Slides. Share. How does that look?
That looks great. It's full screen.
Yay. I think that's what we were aiming for.
Yes. So, Dr. Adamson, what I'm going to do is we'll give it another 5 minutes. And then I'll do a brief introduction and let you get started. I'm happy to monitor your chat box if any questions come up, if that would be helpful for you.
Great, thanks. Yeah, Amy Morris also said she was going to try to be on to help out as well.
Okay.
We haven't planned exactly how that will go.
We're flexible.
You never know. Maybe a second pulmonologist would be useful. Who knows?
I imagine the more pulmonologists, the better.
As long as they all think the same thing.
Yeah.
We don't want different opinions. Has anybody, I'm going to use poll everywhere. Do you know if anybody's tried that out for this?
Yes, I have seen 1 or 2 people try it out. I think that it works well. We just have to all collectively overcome the activation energy of, spending 30 seconds to log into poll everywhere. I believe that people can do that.
Okay. Maybe I'll just leave that up at the moment.
Yeah, great.
And then people can.
Then people who are already on can go ahead and just text Rosemary Adams 633.
Yeah, so you can, the majority of the polls are answerable by text. There's a couple that you need to be logged in like online. If you sign up on the texting, it then gives you like the click button that will take you to it online.
I see.
Yeah, how many people do you think will join?
Usually for a core teaching conference, we have around 20 to 25 maybe people. So we have we have 14 logged on, and some of those people are teams of residents.
Yep.
Yeah,
that sounds great. So the free poll everywhere gives you a cap of 40 respondents.
Oh,
so I was just hoping that we weren't going to get absolutely everybody and that they'd be horribly disappointed.
I would say that we would be breaking records if we had 40 poll everywheres.
Yeah, I figured that was one of those sort of what's the right word? It's not a win-win, but it wouldn't be. It's like it's not the worst thing to go wrong if you have more people than you can accommodate on your polling.
It's true.
If people are in rooms together, I'm more than happy for them to chat and answer as a group or individually, whatever they prefer to do.
Okay.
Just
good.
Just to be explicit, I know that people in rooms together are likely to be chatting about the answers, and that is a-okay. We all learn best from our peers. So you'll learn better from talking to the people in the room with you than from me. So please do it. Great. Do you like to wait until a few minutes after the hour before starting?
It depends on how many people log on by 12:30. I would say that this is a pretty good showing for 12:29. And so I say that in a minute, we'll go ahead and start if that works for you, unless you want to give it a couple minutes for Amy.
No, it's fine.
Okay.
She'll catch up. Or not.
Okay. Med C, I love you're using your camera. I don't know if they can hear me. All right. Hi. Okay. So, yeah, we have quite a few people on. So let's go ahead and get started. So thanks for joining, everyone. I'm Sarah Bliss. I'm the Inpatient Harborview Chief, and we're happy to have Rosemary Adamson with us today. She is one of our pulmonary and critical care attendings. You practice at the VA as well as just the VA? Okay, yep. Just the VA. And she'll be talking to us today about interpretation of PFTs. So if any questions come up, I just throw them in the chat, and I will unmute myself, and I can pause this if needed. And then I think we're using Pull Everywhere today. So if you guys want to text Rosemary Adams 633 to 37607, then you can be ready for that.
Yep. Or you can go on a web browser and type in that pollev.com. Is that a / Rosemary Adams 663 and join in? Excellent. We're talking about PFTs. And what I hope to do is cover the things that I think are important for internists. And so here are my learning objectives for you all. And they are, by the end of this, if you come today, reviewing already, you can also identify lung volume, specifically lung capacity, functional residual capacity, vital capacity, and residual volume on spirogram.
Rosemary?
Yes.
Sorry, is anyone else having some breakup with the noise? Yes, okay. We're having a little bit of trouble hearing you. Can you try to repeat what you just said?
I can repeat. If there's an option for me to call in, I would love to do that.
Oh, to call in. You should be able to call in.
Why don't I do that?
Okay, that sounds great. And in the meantime, yes, I can put the Pull Everywhere link in the chat.
I can go back to it.
Perfect.
There we go. All right. The perils of Wi-Fiing everywhere. Wi-Fiing here and your Wi-Fiing there, and
yeah,
it's a little bit too much Wi-Fi.
So much technology.
20. See, it's lucky we started on time.
Yeah, exactly. Okay, I think we should be good now.
Hello, can you hear me? Is that better? Great. Okay, we're talking about PFTs. We're still going to talk about PFTs. I haven't changed my mind or my PowerPoint. And the learning objectives, as I was describing, we'll talk about biological determinants, predicted PFT values, make sure that you all can expand at least some of the alphabet soup of PFTs, specifically FVC and FEV1. We'll talk about two different methods to diagnose obstruction. We'll define restrictive pulmonary pathophysiology, and we'll talk about at least the two main causes for that. And by the end of this, I hope you'll be able to identify 3 common patterns of PFT abnormalities. So, a spirogram. I'm starting with this because we're going to review some of this alphabet soup of PFTs. And so how do we know what these values are? So this is an old spirogram. They're mostly pretty electronic these days, but I think thinking about the old system helps to sort of visualize what we're thinking about. So here's a person. I hope you can see my arrow. Can you see my pointer arrow? Pointing at the person? Yep, great. So this person appears to be connected in a rather strange way through this tube to this bucket. The bucket has water in it, and then this is inverted bucket, which means that when the person breathes, the air inside the inverted bucket, the level of that bucket will go up and down as they breathe. So as they breathe in, they'll suck air out of that bucket, and it will go down. Whoops, clicked by mistake. And then that is connected by this rope string over this pulley system to this pen that is then drawing. So as they breathe in and out, there are these lines drawn. And so that's tidal breathing. And then they take a deep breath in and they reach their total lung capacity, and then they breathe all the way out, and they're left with the residual volume, which you cannot measure by spirometry. Spirograms can't measure that. And then they go back to their tidal breathing again. And there are a number of parts of the alphabet soup that I'm not going to get into because they're not so important for internists. But I do have my first question for you, which is, which of these numbers represents the FRC? And hopefully Poll Everywhere is working and the little spirogram should be visible. So which one of those is the FRC? Great. Are you seeing the responses, or is it blank for you?
We're seeing the responses.
Great. Clearly, everybody's totally brilliant. You're right. Number 5 is the FRC. And the reason I focused on number 5, the FRC, is that that is the happy point of the lungs, an important volume to know about. You know, there are other ones which are somewhat important as well, like the total lung capacity, the vital capacity, which one of the terms I said I wanted to make sure you could expand is the FVC, the forced vital capacity, but a vital capacity does not need to be performed by a forced maneuver. It can be a slow maneuver. So you will see vital capacity and FVC and SVC at different times when looking at PFTs. They all refer to the vital capacity. It just depends on how it is performed. And then residual volume, as mentioned, that's a volume that we cannot measure by spirometry. Why is the FRC the happy point of the lungs? It's the happy point of the lungs because it is the volume, the resting volume of the lungs. By resting, I mean that your muscles are resting. So if you have none of your muscles of respiration active, then the volume of gas in the lungs will be the FRC. That occurs at the end of a tidal exhalation, and is the point at which the inward recoil of the lung parenchyma, which, if left to its own devices, if separated from the chest, will just collapse into a little tiny thing, and the outward recoil of the chest wall. The chest wall at FRC is trying to spring open. So the point at which those two are balanced without any muscles being active is FRC, and that's why it is the happy point of the lungs, point of balance. So next question for you all is to interpret these PFTs. So this is again a poll everywhere, and you get a choice of what they show. And those of you in rooms together, you're very welcome to chat among yourselves and decide together or vote separately. Great. So these PFTs, great. It's always good when there's a spread of answers. So these PFTs show normal lung function. They do not show obstruction. We will talk more about that in a bit, but obstruction is defined by an abnormal FEV1 to FVC ratio, a reduction in that ratio, listed here. And they don't show restriction. They're normal. And you can tell they're normal by looking at the column that says percent predicted. And those percent predicted are all pretty close to 100. Pretty close to 100, not exactly 100. We'll talk a little bit in a moment about what's the upper and lower limit of normal around 100. Where does that percent predicted come from? Well, the real question is, where does this column, this predicted column, come from? Because that actual column is telling you what that patient did, or that person. And then the predicted is what we would expect for that person. And then percent predicted lets us know how close they were to what we predicted. And so is their lung function normal? So where on earth does this predicted column come from? How do we work that out? So this is one of those polling type questions where you'd actually have to be logged in online to answer. It won't take a text message response, I believe. Great. So people can type in all the things that they think go into the equations that are used to calculate predicteds. Great. So you I love historically. I'm wondering if the historically refers to race. So the important determinants are in there. I'm going to pick out height, age, and sex. And then I'm going to talk about race. So height, I think it makes the very most sense of the lot. The size of our lungs is really driven by our height, not by our weight. Our weight varies around it, and when our weight gets excessive, then our lung function can change, but we consider that pathology as opposed to normalcy. Lung function doesn't really change with weight within, a range, even into the overweight category. It's only once people are into the sort of obese or morbidly obese that it really changes their lung function. Age, absolutely. It's really sad. We are all past our lung function peak, every one of us on this Zoom call. Your lung function peak is probably around the age of 20 or 25, and it's just downhill from there for all of us. And then sex, because it is the sex that you are born with as opposed to your gender that determines your lung function. And then I will also mention race. Race is used in a number of the calculators, but I fear it might be inappropriate. And there are actually a number of working groups who will be talking about whether or not we should really be doing that going forward, for example, through the American Thoracic Society. There possibly maybe some change in lung function based on ancestry and the specifics of where you're from, but probably not race. So let's go on to our next question. So when we were looking at those PFTs before, there was the actual column, the predicted column, and then the percent predicted column. And those PFTs were normal, although not every single number was 100%. In fact, none of them were 100% exactly. So what range is considered normal? Great. 73% of respondents have got it. It's 80 to 120%. Why do we do that? Oh, I was going to show you a spirometry maneuver. I'll come back to that in a sec. I'll just reinforce that PFT predicted values are based on height, sex, and age. And like all physiological variables, PFT values fall on a normal distribution. And so this 80 to 120% of predicted is supposed to capture 95% of normals. So there will still be that 5% of people split between above and below those limits on normal, but it's 80 to 120% of predicted. So I had intended to show a FVC maneuver, spirometry maneuver. This involves me stopping sharing my screen and then resharing my screen. So you're going to see my email for a short moment, just a short moment, while I click to this. Now you should be seeing YouTube, and I'm going to play this, yep, and hopefully you'll see it. So this gentleman, he's wearing nose clips, he puts this thing in his mouth, he takes a deep breath in, he blows out, and you can see up here these two graphs. And then he takes a big breath in, and you can see the bottom part of it. We'll just do that again, really quickly. Nope, go back, play. So he puts on his nose clips, gets a really good seal around his device, takes a deep breath in, then blows out hard and fast as he can. And you can see on this graph, which is a volume versus time graph, that there's nothing more coming out, and then he takes a deep breath in. So just in case anybody hadn't either done or seen a spirometry performed, that was to give you a sense. So it's actually quite hard work. That gentleman didn't make it look as hard, or maybe it's because we're lacking the sounds, but it's quite hard work. For anybody who's done it, you're welcome to put in the chat box how you felt when you were doing spirometry. When you're blowing out, so down on this graph here in the bottom left corner, this is a volume on the y-axis, time in seconds on the x-axis. And normal individuals will blow out, normal young individuals will blow out about 80% of everything that's in their lungs, 80% of their vital capacity in the first 1 second. That's their FEV1, forced expiratory volume in 1 second. And then they'll get out almost all of the rest of it in the next 2 seconds. And by 3 seconds, they're very close to plateau. They often have reached a plateau. And then they're asked to keep blowing to prove that they've really plateaued and that there's nothing left to come. And that means that you're pushing down at residual volume, but there's nothing more to come out. You're all the way down at residual volume. It feels really uncomfortable. You're welcome to try it. It's a deep breath in, and then you blow out. And you're like pushing and pushing. I guess if you're in a room with other people, you shouldn't do that during COVID. But it doesn't feel very comfortable. And if the patient doesn't do very good maneuvers, they'll be asked to repeat that up to 8 times. And then that volume time curve gets converted to what we're used to, this flow volume loop. So flow on the y-axis and going upwards in positive numbers is the expiratory flows, and going downwards in negative numbers is the inspiratory flow. And so you see the person blowing out on the top and then breathing in. And there's a little tick mark that shows where this person had reached their FEV1. So you can see that this volume on the x-axis of the flow volume loop, that represents the forced vital capacity. And the little tick mark shows you where they've reached their FEV1, and it's really almost all of their vital capacity. It's about 80%, and that's where you get this ratio, the FEV1 to vital capacity ratio. So in normal, young, healthy individuals, it's around 0.8. A little higher for women, a little lower for men. Aha, next case. So interpret these PFTs, and I'm giving you some options. So I'm actually saying restriction can be diagnosed from these PFTs because, your choices are because the FVC is reduced, or because the FEV1 to FVC ratio is normal, or because the TLC is reduced, or because you're not quite sure. Good. Okay, that's great. So the definition of restriction is a reduction in TLC. So a TLC below 80% of predicted. So if there is one single best answer to this question, it is because the TLC is reduced. However, spirometry suggests restriction even when we haven't measured lung volumes. And in this case, the spirometry suggests restriction because the FVC and the FEV1 are both symmetrically reduced, and the FEV1 to vital capacity ratio is normal. So the top two contribute, but it's that total lung capacity being reduced that really defines and diagnoses restriction. So I would like you now to name some diseases, or buckets of diseases, types of pathology, or specific diseases, whichever you find easiest, that lead to restriction. Oh. It's funny, the system clearly takes, if you put in two words, it seems to separate them and put them separately. Great. So there's a number of interstitial lung diseases that have been typed in. I'll just make the point that exposure to asbestos does not necessarily give somebody asbestosis, which is, asbestosis is an interstitial or diffuse parenchymal lung disease that can lead to restriction. There are many other DPLDs or ILDs that have been listed here, so pneumoconiosis, fibrosis, which I think was supposed to have pulmonary before it. So I think one of these might have been coal workers or coal miners pneumoconiosis. They're kind of hard. Silicosis, berylliosis, hypersensitivity pneumonitis. Indeed, those are all diffuse parenchymal lung diseases that could lead to restriction. And morbid obesity, as mentioned earlier, can do. And so can neuromuscular diseases, so weakness. And so there are two buckets that are coming out here. One bucket is diffuse parenchymal lung diseases, and one bucket is chest wall disorders. So as we talked about before, the FRC is from this balance of these two forces, the inward recoil of lung parenchyma and the outward recoil of the chest wall. And so diseases that cause restriction fall into those two buckets, that there's something wrong with one of those. And so restriction occurs when there's either increased lung recoil, as you would see in interstitial lung diseases, which are also probably more correctly referred to as diffuse parenchymal lung diseases. And then when there is a decreased chest wall recoil, so that's not pulling out as strongly, it might actually be pushing in a bit. And so chest wall abnormalities, so scoliosis had been listed, or morbid obesity would fit under this bracket, and then weakness is the other main cause of the decrease in chest wall recoil and restriction. So this slide I put over on the left. I expanded the alphabet soup of PFT lung volumes to make it clear what we're talking about over on the right. I'm repeating myself a little bit here, but I'm also pointing out how the lung volumes, each individual lung volume can look a little bit different in interstitial lung diseases versus when somebody has weakness as the cause of their restriction. So I included this because you can look at the rest of the numbers in somebody's PFTs to try to think about, is this restriction more likely to be a chest wall problem or weakness, or is it more likely to be a diffuse parenchymal lung disease? So when somebody has an ILD or a DPLD, typically they have a symmetric reduction in all of their lung volumes. And so it's often the case that they're all reduced, maybe not exactly the same amount, but they're all clearly reduced. Whereas if somebody has weakness, then the exact reduction in each of their different lung volumes is going to depend on which muscles are weak. And are they all symmetrically weak, or are some of them weaker than others? So what am I getting at here? Well, you can imagine that when we blow down to residual volume, that takes muscle strength. And so if you are weak, then your residual volume may actually end up normal or increased, despite that your total lung capacity is reduced. Because if all of your muscles of respiration are weak, then you're weak and you can't breathe in to such a high total lung capacity, but you also can't blow out to as low a residual volume as before. Whereas in interstitial lung disease, all of the numbers are reduced. The other big difference that you'll find on PFTs is if there's been a DLCO measured, and then you'd expect that the DLCO would be reduced in interstitial lung disease and not really, or only just borderline reduced in a neuromuscular weakness or chest wall deformity issue. I'm taking a little breath because I've gone through a whole bunch of things, and I wanted to give a moment for anybody to type into the chat box with any questions. We're about to move on to obstruction. So we've done a whirlwind tour of normal PFTs and the predicted values for PFTs coming from age, height, and sex. And then we've talked about restriction being defined by the total lung capacity. So these are some pretty abnormal PFTs. I haven't pointed out before, I don't think, on the flow volume loop, these black dots show you the predicted, the normals. So this patient is really failing to get anywhere near their peak expiratory flow that they'd be expected to reach up here, and then they're not reaching their expected forced vital capacity, nowhere near it. So I've got a question related to this one. And the question is, these PFTs show obstruction. And why is that? Great. So obstruction is defined by a reduction in the FEV1 to vital capacity ratio. And so in this patient, the predicted FEV1 to vital capacity ratio was 0.79, and this patient had a ratio of 0.26. There are also a number of other things that one can see in this patient. So the flow volume loop has some very classic scooping, which is, the flow volume loop is really useful for pattern recognition. It can be useful for seeing if people did a good maneuver, and it's useful for pattern recognition. And so the pattern you see here is this severe scooping that we see in obstruction. This patient also has a total lung capacity that is 159% of predicted. So that means they have hyperinflation. The TLC is above 120% of predicted, and the reason is that their residual volume is so very high. They have air trapping, bringing their residual volume up to nearly 400% predicted. So to be clear, it's the FEV1 to vital capacity ratio, reduction in that ratio, that defines obstruction. Now, that patient also had a reduction in their forced vital capacity and actually their slow vital capacity. And you can see a reduction in vital capacity in either restriction, and then you also see a reduction in TLC, or in severe obstruction causing air trapping. And so here I made another double-ended arrow so that it's easier to compare. That the vital capacity here in normal was this size, and when I put that same size up there, you can see the vital capacity has got squished a bit. So when there is air trapping, the residual volume increases and the total lung capacity increases, but the balance of forces is such that the vital capacity typically gets reduced in the middle. So that as somebody has air trapping from their bad obstruction, then their vital capacity will be reduced. And so if you only have spirometry, then you'll see, what I mean is, if you don't have lung volumes, if you don't have the TLC, then if you see that somebody's vital capacity is reduced, you don't know why that is. If they have severe obstruction, then you'll be very suspicious that it's from air trapping. But people can have two disorders. So people can have obstruction and restriction. So they could have COPD and an interstitial lung disease. This is making the point that, or emphasizing the point that spirometry will suggest restriction, but not actually define and diagnose it. And I'll take this moment to answer the question from Amy about how is obesity different. So I had emphasized how in weakness, the RV can be normal or elevated. In obesity, it's unlikely that the RV is going to be particularly elevated. The volumes will all come down over time. They actually fall in a certain order as people get more and more obese, which is not necessary for internists to know. But to end up with a reduction in your TLC, people don't normally reach that point until their BMI is 45 or higher. So it's pretty unusual to see a reduced TLC from obesity until people are truly morbidly or very extremely morbidly obese. I'm not quite sure what the categorization is. So, new question about obstruction. So this patient has obstruction. Is that true or is that false? That was just an easier way to ask the question on Poll Everywhere. Does this person have or not have obstruction? Great. Almost an exact division in people's thoughts. So it depends on how you diagnose obstruction. This set of PFTs, I would suggest to you, is very suspicious of obstruction, no matter how you think about obstruction. This person has a total lung capacity of 123% of predicted, so they have hyperinflation. Their residual volume is 152% predicted. They have air trapping. We tend to think of those as being caused by obstruction. But depending on what you've been taught about how to define obstruction, you may question whether or not they actually have obstruction because their FEV1 to vital capacity ratio is 0.73. So I imagine that many of you have been taught that obstruction is defined by a FEV1 to vital capacity ratio of less than 0.7. And that is the gold guideline. So the Global Alliance Against Obstructive Lung Disease advocates for defining obstruction with a fixed ratio of 0.7. On the other hand, other organizations, for example, like the American Thoracic Society, advocate for defining obstruction by a ratio, an FEV1 to vital capacity ratio that is less than the lower limit of normal. And the lower limit of normal is going to depend on age. And you can't just know it in your head like the 0.7 fixed ratio. So in this case, the lower limit of normal was 0.73. So this person is still sort of only borderline. Interesting though, you look at the forced vital capacity, and they did a forced vital capacity of 4.96, but a slow vital capacity of 5.78. I told you that the vital capacity can be measured as a forced maneuver or a slow maneuver, but it's still a vital capacity. So how does this person have two different vital capacities? They don't. They only have one vital capacity. And the largest vital capacity you can measure is going to be the closest to their true vital capacity. In fact, once this patient was given a bronchodilator, then their forced vital capacity became larger, actually even larger than it had been when it was a slow maneuver. And then when they did a slow maneuver after bronchodilator, they had an even larger vital capacity. So when their airways have been opened up by bronchodilator, or when they're given longer to breathe, allowed to have longer to breathe out, they manage to document a higher vital capacity. The larger the vital capacity, the closer it is to the truth. And this 5.93 may truly be this person's true vital capacity. When people have obstruction, they've got narrowed airways. They've got an increased resistance to flow, resistance to breathing out. And so it can take them longer to breathe out the same volume. And that's how the FEV1 gets reduced, because you can see on this person's volume time curves that pre-BD and post-BD, you can see that the slope of the curve became sharper. They're able to breathe more out more quickly. Their flow rates increased. Their peak expiratory flow got higher. So this patient does actually have obstruction. They also have a robust bronchodilator response, which would be consistent with having obstruction. And the reason why, and I suspect that a reason why half of you thought that they did not have obstruction is because they didn't meet that gold criteria for having obstruction, which is an FEV1 to vital capacity ratio of less than 0.7. That's just in case poll everywhere wasn't working. So the FEV1 and the FEV1 to vital capacity ratio, like all our other PFT numbers, change with age. They go downhill with age after about the age of 20 or 25. So here I'm showing a graph of FEV1, but you can also think about it as FEV1 to vital capacity ratio. The same, it shows the same graph. And it's showing the changes with age. And the colors, you have the greens for individuals who are truly normal. And then you have the reds who are the accepted false positives. They're outside that, I'm showing you the bell curve here. They're outside that 95% confidence interval. So they're outside that 95% of the population. The purples and the blues are people who are inside that 95% of the population. So the black line that I've put through the middle would be sort of the median value for the FEV1. And then the purples here are young people who truly have obstruction, but they wouldn't be defined as having obstruction if you use the fixed ratio of 0.7, because our normal FEV1 to vital capacity ratio is so high when we're young that to reach a ratio of 0.7 doesn't happen with young people until their disease is really bad. So when using a fixed ratio, we misclassify young people who truly have obstruction as not having obstruction, as in this case I just showed. We also misclassify some number of older people as having obstruction when they actually don't. And then there's some age in the middle, around 50 or 55, where using a fixed ratio of 0.7 actually is exactly right. That is the lower limit of normal for the FEV1 to vital capacity ratio for people around the age of 50 to 55. So why does GOLD use this? They recommend using this fixed ratio because you don't need to input demographic data if you're just using a fixed ratio. You can use a spirometer and just get somebody's FEV1 and their vital capacity and then work out what their ratio is and then classify them as either having obstruction or not having obstruction. It's simple. You can do that very quickly. You don't have to have complicated algorithms to work out what the lower limit of normal of the ratio should be for that age, for that individual, but it misclassifies. All right, more about obstruction, but a little bit different. I've got another question for you. So I'd like you to pick which one of these is truly a positive bronchodilator response. And the things you're trying to work out are, what is the absolute increase in the FEV1 and the absolute increase in the FVC? Do you need both the FEV1 and the FVC to increase, or can it be either of them? And what is the percentage change? Great. So you are, I put in 2 Bs. That makes it harder. Well, doesn't matter which one of the Bs you pick, it's wrong. The answer is C. It can be either the FEV1 or the FVC. It doesn't have to be both, and it needs to be a change of at least 200 mils and 12%. So it can be, if somebody has a change that is 200 mils or 210 mils, but only 10% increase, then that wouldn't count. Oh, I added that one. It was one of my last minute ones today. Interestingly, the more robust someone's bronchodilator response is, the more likely it is that they have asthma versus COPD. So I've been talking very much about PFT interpretation as opposed to pulmonary diseases, but COPD patients have a fixed obstruction, which means that it does not normalize. So post-bronchodilator, it wouldn't go all the way back to normal. In asthma, you'd expect that at least some of the time, their lung function will go all the way back to normal and they'll only have obstruction some of the time. And the bigger the bronchodilator response, the more likely it is that somebody has an asthma phenotype. All right, so one more question, and let's see if I made typos on this one. Oh, goodness. What is the next test you should order for this patient based on these PFTs? So CBC, complete blood count, chest CT, or TTE, transthoracic echocardiogram. Great. Well, the first answer, complete blood count, is a little bit of a unfair question. You'll notice down here that it says DLCO corrected. So I put this one in because the DLCO has to be corrected for hemoglobin. And so if this DLCO had said uncorrected, then CBC would have been the correct answer. But this person's DLCO has already been corrected for their hemoglobin and is still low, 52% of predicted. So what can be causing that reduction in DLCO? Well, chest CT suggests that people think that they've got a lung problem to explain their reduction in their DLCO, which they might. You know, they could feasibly have emphysema but not have obstruction and still have a reduction in the DLCO, or they could feasibly have be early in their interstitial lung disease such that they only have a reduction in DLCO but still have a normal PLC. Those are possible. The thing I would be much more concerned about is that this person has pulmonary vascular disease because they don't have obstruction, they don't have restriction, so I don't think that they've got they don't seem to have a lung disease to explain this reduction in DLCO. So I'd be concerned that they might have pulmonary hypertension and send them for a TTE. Like I say, it's not completely wrong to say chest CT. There are a few instances where you could get this pattern and actually somehow it's their emphysema that doesn't manifest as obstruction, or that it's their interstitial lung disease, which for some reason doesn't really manifest as restriction. And that will happen from time to time. This patient certainly does need a better workup. And if they're complaining of dyspnea, then getting a TTE and a chest radiograph and then maybe going from there would make a lot of sense. This pattern is referred to as an isolated reduction in DLCO. Isolated because there's no obstruction and there's no restriction. there's just the reduction in DLCO. And so the three patterns of PFT abnormalities that I wanted to review today are obstruction and restriction and the isolated reduction in DLCO. So this is my summary slide, where I wanted to remind everybody that PFT predicted values are based on height, sex, and age. And like so many physiological parameters, they fall on a bell curve. And we say that 80 to 120% of predicted will roughly capture 95% of normal individuals. The patterns that we've talked about normal PFTs and normal spirometry. I'm showing you a normal flow volume loop there. And then I'm showing you an obstructive flow volume loop with that scooping. And obstruction is defined by having an FEV1 to vital capacity ratio that is less than the lower limit of normal. The gold criteria are that that ratio would be less than 0.7. I advocate for using the ATS criteria of lower limit of normal so as not to misclassify the younger and older populations. Restriction is defined by a reduction in TLC, so a TLC below 80% of predicted. And typically, it'll be suggested by the spirometry, because typically the spirometry will show a reduction in both the FVC and in the FEV1 that are quite symmetric, such that the FEV1 to vital capacity ratio is greater than the lower limit of normal, or is normal. And the pattern you'd expect to see there on the flow volume loop is you'd expect to see sort of a shrunken flow volume loop where the FVC is reduced because that's what the x-axis is on a flow volume loop, but the peak expiratory flow is normal or sometimes even elevated because their lung parenchyma is collapsing down so easily, has a sort of greater tendency to collapse down. And then we've talked through how the vital capacity can be reduced by obstruction, where there's air trapping, squishing the vital capacity, and also pushing the total lung capacity up. Or the vital capacity can be reduced by restriction, which can be due to weakness or other chest wall disorders or diffuse parenchymal lung diseases. And then the third pattern of PFT abnormalities to be aware of is the isolated reduction in DLCO, which is concerning for a pulmonary vascular disease and should prompt a TTE. And there is time for questions and also time for you to scan the QR code and write an evaluation.
Great, thank you, Dr. Adamson. I'm just going to put the link in the chat box as well while people ask any questions if they have them.
Right. Thanks for participating in the polls. It's only fun when you do.
All right, if everyone can please fill out that speaker eval, they're really important for our faculty, so we appreciate it.
Yeah, thank you for taking the time to do that.
Okay, is there
Great.
no questions? Thank you so much for your time. Yeah, and thanks everyone for joining.
Good to see you all. Thank you so much. Take care. Have a good day.